we're talking about heart failure in older adults. And for those that don't know me, if you're new to this session, my name is Donald Jurovich. I am a professor of geriatrics, and I also am the principal investigator for our HRSA project, which is sponsoring this programming called the Geriatric Workforce Enhancement Program. And I didn't actually put a mention in here, but I should. If you are interested in any of our educational materials, if you just go to Google Dakota Geriatrics, it'll bring you to the website and you'll see all of our offerings on either social media. We've now got an online curriculum where you can get a GeroChamp digital badge, as well as an assortment of other educational products that we have. And I mentioned the social media one. We have social media feeds on geriatric knowledge to Twitter, and we're getting some feedback from folks on Twitter as to like, do you really still want to be part of Twitter? And the answer is, I guess, to be determined. So we're still active and live on Instagram, Facebook, and Twitter. But we might also add one of the new social media accounts called Mastodon, which is apparently a British-based Twitter equivalent. So that's just a shout out to our educational products. Next slide, please. So the goals today are to report how age is a risk factor in of itself for heart failure, in addition to all the other risk factors, which are coronary artery disease and diabetes. We want to identify the clinical features of heart failure, whether it be systolic or what we call diastolic heart failure. And we want to have a little bit longer discussion about how to manage. And I guess I should have spelt manage a little bit better rather than mange, which I guess dogs get. So I apologize for that. And then we want to evaluate health disparities associated with heart failure. So those comments will be interjected throughout the talk. Next slide, please. So there are a lot of people with heart failure in the U.S. Interestingly, it's a disease of the geriatric or older adult population. And as you approach the age of 80, up to 13 to 14% of people will have some form of heart failure. And of those people, 3/5 of them have 5 or more chronic conditions. So you can imagine that disease burden. And most importantly for our considerations is that last point of 50% or half of them being functionally impaired, in addition to either as a result of their heart condition. Next slide, please. The big thing I want to bring your attention to that second point, that 50% of all costs are linked to hospitalization. So that's why we spend a lot of time thinking about how to address heart failure. Back when I was working in the Veterans Administration Hospital in Chicago, I recognized or realized that the top admission to the VA system was schizophrenia. The second one was heart failure. So just kind of an interesting, number 1, number 2 top diagnoses for admissions to the VA hospitals. Next slide, please. Yeah, so the question is, why do people get heart failure? And I think it's safe to say that it's multifactorial. The big drivers are hypertension and coronary artery disease, particularly if they're poorly controlled. So all those people running around with systolic blood pressures of 150/88 are likely to have progression of dilated cardiomyopathies and heart failure. Valvular problems such as rheumatoid heart disease and a variety of other valvular, whether they're congenital or acquired, valvular diseases can lead to heart failure. And as you can imagine, if the valve is blocked and reduces the flow, it causes the heart strain, and then logically the heart strain causes heart failure. There are dilated cardiomyopathies. These are often seen postpartum. It's a rare occurrence, but that is an example. And then there's hypertrophic cardiomyopathy. So that's just the opposite of the dilated. That the hypertrophic is the enlarged heart, which is under strain. And then finally, there's the version of what we call restrictive cardiomyopathy. So that's where the band around the heart gets fibrosed, either because of amyloid or maybe a past infection with fibrosis. And it just, the heart is pretty much okay, but the coating around the heart is becomes restricted. And so then that can induce heart failure. Actually, it's one of the diagnostic signs for restrictive cardiomyopathy is to look at the neck veins. And if somebody is just breathing normally, as they take a deep breath, or not, as they breathe in, not a deep breath, but as they breathe in, you see the jugular venous vein distend or rise. So that's usually an indicator of restrictive pericarditis. Just a little clinical pearl there. Next slide, please. So there's two types of heart failure, and we're going to be talking about heart failure with reduced ejection fraction, and typically based upon an echocardiogram or a SPECT scan or nuclear radiogram that represents an ejection fraction of less than 40%. And then there's the heart failure with preserved ejection fraction. So anybody with ejection fraction of greater than 40%, so usually 45% or better, would be considered heart failure with preserved function. And there's differences in both the management and overall etiology of these conditions. So if you're younger than 65 and have heart failure, 90% of that's going to be with that what we used to call systolic heart failure or reduced ejection fraction. Whereas once you get into the Medicare group, it's a little bit different, where well, between the two genders, half will have heart failure with preserved ejection fraction. So there's a little bit of a skew towards women having the second type of heart failure more so than men as they get into their older years. Next slide, please. So some of the drivers of heart failure, women tend to have heart failure a little bit more than men. Diabetes background as well as hypertension. So you go like, well, wait a minute, 60% of the older adult population has hypertension, and as they get older, it goes up to 80%. So, what's up with that? Well, it just means that there's a high risk factor, and it makes for a strong case for why you want to be very aggressive with hypertension control. Diabetes is also a risk factor for heart failure, as is alcohol overuse, as well as dyslipidemia, primarily through the cardiovascular atherosclerotic process. And then atrial arrhythmia, so AFib and flutter can induce heart failure with preserved ejection fraction. Again, the heart is able to squeeze the blood out, but it, for whatever reasons, if it's fluttering, it can't give a strong squeeze, so that's why it becomes preserved ejection fraction. Next slide, please. So overall, the clinical features of heart failure are exertional shortness of breath. People complain of fatigue, orthopnea, where they're getting breathlessness when they're lying flat. And they may also complain of leg edema. So those are the cardinal observations with both preserved and reduced ejection fraction heart failure. Next slide, please. Some of the atypical presentations of heart failure, which is, again, always remember we're thinking about the atypical things that happen in the older adult, and here we get psychomotor slowing, lethargy, confusion perhaps, anorexia and weight loss, irritability. I have to comment on the side here about irritability. I was just reviewing a journal manuscript article from Japan, and they were asking questions of older adults about whether their experiences with young children altered their attitudes. And one of the questions was, do you think your interactions with children made you a more pleasant person? And I'm thinking to myself, boy, it must have been lost in the translation because, they're assuming that there's a bunch of grumpy old men and women that were, interacting with these children by saying that you became more pleasant. So anyways, that would just kind of amused me when I read that. And then the other issues with heart failure, getting back to this, is sometimes you get diffuse abdominal pain, and that could be just from the fluid accumulation. And then also you might get constipation or diarrhea as a atypical manifestations of heart failure. And then I would just say lastly, which I did not include on here, is that falls might also be associated with with heart failure. Okay, next slide, please. Okay, so some of the clinical findings when you examine the patients is that they may have a rapid heart rate with tachycardia, narrow pulse pressure. So it may be that they have a blood pressure of 130, let's say over 88, or maybe 110 over 77, something like that. So it's a narrow pulse pressure than what you normally would see. Like, usually there's a 50 to 60 millimeter difference between them, between the systolic and diastolic blood pressure. You might see jugular venous distension. We shorten it for JVD. And then hepatojugular reflux, HJR. So that's when somebody presses on the liver area subdiaphragmatically and gives a pretty good squeeze down on the stomach area, or on the liver area. And then you see the vein distend itself when the person's at a 45-degree angle. Sorry, I'm trying to get my camera hand in the right 45-degree angle there. S3 gallop, that's you hear this extra beat in there, and it's like Kentucky, that you might hear. I can't tell you the last time I heard an S3. We're managing heart failure so much better. I mean, this it'll occur, but I just don't see it that frequently. Pulmonary crackles we see a lot of, and so those are, if you rub your hair next to your ear, that would be what the sound of pulmonary crackles might be like. And you might get reduced breath sounds if there's fluid on the lungs or around the lungs, right? So that could be an issue. And then usually you see pitting edema. So when you press in, you'll see a little indentation on the lower extremities, which is to be distinguished from brawny edema, which is where if you don't get any indentation when you press in, and the implication is that the latter, the brawny edema or non-pitting edema, is more associated with lymphedema than with heart failure. So those are some of the differences there. Next slide. So older adults may not have classic heart failure symptoms, and sometimes their clinical signs and symptoms might be due to something else. So like if somebody says exertional shortness of breath, that may actually be a sign of coronary artery disease and angina as opposed to heart failure. So it's always a toughie. That's why we call when we talk about the geriatric 5Ms, medical complexity really gets us, have to put our thinking caps on. So things like if you hear basilar crackles in the lungs, that kind of twisting your hair and getting that kind of crackly sound that you can hear. That could be due to either just simple atelectasis, where the lungs are compressed upon one another at the base of the lungs, or it could be associated with chronic obstructive pulmonary disease. The edema has to be distinguished from venous insufficiency versus kidney or liver disease. Maybe they're malnourished and they have low albumin, or more frequently, the leg edema may be coming from medications like second-generation calcium channel blockers. So if somebody's on amlodipine or felodipine, that can cause ankle edema. So anyways, the point there is the last one is just really have a high index of suspicion. If you hear any of these or see any of these signs or symptoms, always think heart failure. Next slide, please. So the diagnosis is usually made clinically, and it's based upon the symptoms. You can get some other diagnostics, like if you want to get a chest X-ray and it shows cardiomyopathy dilation, or you see on the chest X-ray, sometimes you can see redistribution of the pulmonary artery. So there's like a stronger shadow, from the pulmonary arteries, or you might see a little blunting on the chest X-ray to suggest fluid around the lungs. The EKG is good for diagnosing atrial fibrillation or flutter. Can also suggest left ventricular hypertrophy or ischemic strain or pattern. So if you have ST elevation or former indication of a heart attack through what we call Q waves, those are all types of things that you'd look for on the EKG to help support the diagnosis of heart failure. The big one for the blood test is the BNP, the B-type natriuretic peptide. We call it BNP. Usually that's going to be elevated by a couple of hundred picograms on the blood test. And that usually is a very strong indicator that the heart is not functioning properly. And then finally, the gold standard for all of this is to get an echocardiogram. And it's interesting when providers, are scratching their head and they're not too sure, even if the person had an echocardiogram the previous year, they'll still order another echocardiogram. And I would just challenge that. There's this whole movement to choose wisely, and I'm not sure you need an echocardiogram every time somebody comes up with new symptoms. But be that as it is, the echocardiogram is available for evaluating heart failure. And sometimes people, will have normal left ventricular function, and then it gets reduced for whatever reason. Post-COVID, could be post-influenza, it could be, idiopathic, and any number of reasons why the heart goes in and out of failure. Next slide, please. So it's important to know that the natriuretic peptide levels vary according to age. As I mentioned, the picogram level, so under 100 is predictive of not having heart failure. And then if it's over 500, then it really is highly suggestive for the diagnosis. And you go like, well, wait a minute, what happens between 100 and 400 picograms? And the answer is that if they have a history of heart failure, and if it's elevated over 100, then it's due to exacerbation of the heart failure. If you don't know whether they had heart failure previously, but from a diagnostic test such as an echo or a SPECT scan, nuclear scan, then you may not know whether that 100 to 500 range really represents anything. So anyways, it's kind of a no man's land, gray zone, and it's just important to distinguish, what you know about the patient. So again, if you know that the patient has heart failure, then elevated anything over 100 is probably representative of an exacerbation of heart failure. Next slide, please. So mentioned some additional tests. The second one there is, I think, fairly reasonable, is the radionuclide ventriculography. It's a little bit of a tongue twister. In addition to the third test there, which is the echo, you can also get an echo or nuclear stress test, which again is can be done by exercise bike, treadmill, or by intravenous dopamine or dopamine infusion. So it's kind of I don't want to say the lazy man's test, but it's for people who don't have exercise capacity. And then finally, getting an angiogram to detect any blocked arteries may be important for additional testing, because as we'll see in a little bit here, that coronary artery bypass surgery for 3 vessel or more disease is best applicable to those people who have heart failure in addition to 3 vessel disease. If you have 2 vessel disease or 1 vessel disease, research doesn't really support coronary artery bypass surgery. Okay, next slide. The goals of treatment are to ameliorate, reduce the symptoms, We want to improve the overall function, both in physical, cognitive functioning. Remember, the atypical manifestations of heart failure might be brain fog in the older adult. And also one of the aspirational goals is to avoid acute care, and then ultimately to prolong healthy longevity, right? So ultimately survival. Next slide, please. So generally, we want to address the conditions of hypertension, diabetes, and hyperlipidemia. Some of you may have heard me say this before, but there's new evidence from the SPRINT research study, which really establishes 120 systolic blood pressure as being the ideal optimal goal for blood pressure to avoid heart failure, stroke, and other sequelae that occur as a result of hypertension. So if your blood pressure is 130 to 140, that's actually considered pre-hypertension, and it still leads to worse outcomes than if you had blood pressure of 120 or less. A big one and could be a potentially easy low fruit hanging situation is smoking cessation. When you stop smoking, you do reverse a lot of the risk factors for both lung disease and heart disease. The idea of avoiding non-steroidal anti-inflammatories, so people that are chronically popping Motrin, Aleve, and so forth, maybe not so much the topicals, so the diclofenac or Voltaren gel, probably not such a big deal, but the oral consumption of NSAIDs can really put people at risk for heart disease and stroke, and therefore heart failure. You want to aggressively treat coronary artery disease through all the options of primary prevention, secondary prevention. So addressing the lipid level if elevated with statins and dietary changes. And then likewise applying those plus other interventions for coronary artery disease, including stents, dilation, and bypass surgery. The other treatment is using beta blockers for atrial fib. And I just put a note here that there's really no difference between whether you change the rhythm back to sinus or whether it's just rate control. So a lot of times people give the antiarrhythmics to get the person back into a sinus rhythm. But as it turns out for heart failure, the outcomes are no different whether you have a sinus rhythm or you have an atrial fibrillation, but with rate control, which means that your heart rate is, around 70 to 80 beats per minute. So that's kind of interesting observation. And then whenever managing anemia and hypothyroidism, so as we'll find out in a little bit here that people that are on chronic water pills can develop thiamine deficiency, and as a consequence, you can develop anemia from that. So those are things, sort of, chasing the tail, kind of situation where your treatment causes iatrogenic disease, but nevertheless, we need to be aware of that because people need to be a lot of times on chronic diuretic therapy. Next slide, please. The non-pharmacologic interventions are exercise. I probably should say that again, exercise. And so the reason that exercise works in anybody really with heart failure is that they build up the mitochondria, the little energy packages that are in the muscle. And the only way you can do that is by building muscle. And so that first point there, resistance training, of getting, pumping the iron or doing the stretch bands, those are the things that build up your mitochondria. And the resistance training is preferred to aerobic and core balance training. You say, well, aerobic training increases your oxygen, abilities, and it's true. Yeah, I mean, you might improve your endurance, but again, the resistance training is what builds the capacity, for more mitochondria to actually utilize the oxygen. So if you're getting more oxygen into the system and your system can't utilize it, then you're kind of missing the boat. So that's why resistance training is so important. I put down that salt restriction is controversial because not really clear studies. We consume way too much salt in the United States in general. The average is about 4.6 grams of salt per day, which is pretty much a couple of several teaspoons and of salt. And we only need 2.3 grams to have a healthy salt balance in our system. The other point here is water restriction. That really is reserved for people that have a heart failure less than 40% ejection fraction. It may also apply to those that have preserved ejection fraction, and we'll talk about that in a little bit. And then finally, Medicare has a benefit for rehab if your left ventricular ejection fraction is less than 35%. It's actually been proven to reduce hospitalizations, reduce length of stay, and improve quality of life. Next slide, please. This is a big one. So ultimately, you want people to be able to self-manage their chronic condition, whether it's diabetes, hypertension, heart failure. So really the key point here for self-management and heart failure is to establish firstly their dry weight, and then that they weigh themselves daily, and they either need to notify the primary care provider or the heart failure program if they gain 2 to 3 pounds in weight from their day-to-day measurements, and or they've been given permission by the provider to say, if you gain 3 pounds of weight, I want you to double your Lasix, or here's the water pill Lasix, I want you to go on this if you gain 3 pounds of weight during the course of your measurements. So that would be not only that'd be the highest form of self-management. Now, the only problem with that is that self-management is based upon having your memory intact. And so if your cognition is somewhat of an issue, either due to Alzheimer's or other multi-infarct dementia or so forth, the self-management really then becomes more of a issue for the caregiver than it is for the patient per se. So that's why, as part of our 4Ms, right, that we always routinely screen people for memory loss, because if you happen to have heart failure and you want to promote self-management, the impediment or the barrier is going to be cognitive impairment. Next slide, please. We got other options such as telehealth. There's heart failure management programs. So at Sanford, where I work, we have a heart failure management program. I put down the combined geriatric cardio clinic. It's a rare bird. We put together one in Chicago, and it worked even better than the heart failure program by itself. So once again, it shows that when you put geriatric principles of care into a cardiology clinic, it really makes a big difference. Next slide, please. So the mainstay of heart failure with reduced ejection fraction are the angiotensin converting enzyme inhibitors, or the ARBs. And in addition to that, you want to add aldosterone antagonists. So that would be something like spironolactone, aldactone, and then beta blockers. But basically, the core dual treatment is the ACE and a beta blocker. So that should be the minimum standard for your heart failure treatment to impact better quality of life, better exercise capacity, reduce hospitalization, and really a prolongation of life. I mentioned there the combination medicine of the ACE or the ARB inhibitor called valsartan with sacubitril. That's better known as Entresto. You may have seen TV commercials for Entresto, E-N-T-R-U-S-T-O. And that's also good for somebody who has heart failure less than 35% ejection fraction. Next slide, please. So with the ACE inhibitors, if you're going to start them off, you want to start at a low dose. So if something like lisinopril might be 2.5 to 5 milligrams, and then you start escalating to optimal doses. And then the point there is that they can these ACE inhibitors can lead to high levels of potassium, so hyperkalemia. They can transiently lower the kidney function. And so these are all side effects that we need to be concerned about, in addition to hypotension and the allergic reaction, which is rare, but usually is tongue swelling and angioedema. I think we'll cover this in a bit. Next slide, please. Yeah, so those are the side effects. So up to 10% of people have a cough, and it can start during the first phase of the ACE inhibitor, or it can occur years into the treatment. And sometimes it's difficult to understand or not interpret, but to distinguish whether a chronic cough is due to postnasal drip, for example, and allergies, versus a ACE inhibitor. And the good news is that you can always switch over to a ARB, and see if the cough goes away. And also, I mentioned a lot of these people who have coughs, and this is kind of a rare bird, but I just pointed out, so to be complete, that if they have a cough and they happen to be taking aspirin and they have some wheezing on top of that, that could be an aspirin-induced hypersensitivity syndrome, and that could be causing the cough. And then finally, always think about, because we're interested in geriatrics and older adults, that if somebody has a chronic cough, think about reflux and nighttime regurgitation causing a cough. I had already mentioned the side effect of tongue swelling, so that's called angioedema, and then also just that just a very intermittent bump in the kidney function when you first start an ACE. And again, always watching and monitoring the person who's just started on it for elevated potassium. And then one of the final side effects is gastrointestinal distress. That's pretty rare. I haven't really seen much of that. Next slide, please. So again, it's important to monitor the electrolytes after you started ACE inhibitor, and with the key point of watching the potassium levels. So usually you get a value 1 week, and then monthly thereafter for 3 months to make sure that the potassium doesn't go haywire. And it's rare, but it happens. And it usually happens in people with low renal function. So if their creatinine is 1.5 or higher. Next slide, please. Yeah, just the ARBs are identical to the ACE inhibitors. They all inhibit the renin system. So these are angiotensinogen 2 receptor blockers, and they just knock out the hormone system, the renin hormone system that drives salt retention. Next slide. And there's no difference between ACE and ARBs in terms of impacts. They used to say that the ARBs are so much better, and really, after all the research, they're pretty equivalent in terms of their outcomes. Yeah, so these are things we talked about. I just have to be careful. A lot of these older adults, particularly in the 80 to 90-year-olds with heart failure, they tend to run very low blood pressures. And so just even a little wisp of an ACE inhibitor, 2.5 or 5 milligrams of lisinopril, will put them over the edge. And so you're always walking a very delicate balance of not knocking out their blood pressure. Next slide, please. And then again, the beta blockers, the more they slow the heart rate down, the better they are. Not, of course, going below 50 beats per minute. You have to be careful if there's wheezing or a history of wheezing, because beta blockers can make it worse. If they have a prolonged PR interval, so generally we do get EKGs when managing heart failure. And then to be careful with hypotension. And in particular, just a word to the wise, when people are on carvedilol, which is an alpha and beta blocker, older adults are at higher risk for hypotension with carvedilol than with the other beta blockers, because particularly in men, if they're on Flomax, which is an alpha blocker, the combination of the carvedilol and the Flomax, which knock out both the beta and alpha adrenergic system, then they've got nothing in their adrenergic system to compensate, right? So and people that, by the way, people that have cardiac transplants, they have no adrenergic sympathetic system to drive their heart rate, because they clip the the vagus nerves, right? And all the nerves that innervate the heart are no longer there. So they can't really control their heart rate, through their autonomic nervous system. Next slide, please. Yeah, so the way the beta blockers work is that they impact that adrenaline system, right? So they block that, and that adrenaline system is always higher in heart failure. And you can imagine that, it's like deer in the headlights, that your heart's beating really fast and it's not beating strong. That's all generates a sympathetic, reaction. The beta blockers help reduce sudden death. It actually helps by slowing the heart rate down, get a better squeeze. It helps it fill up better and then squeeze. The point is that these 3 beta blockers are the ones that work. There are a handful of other named beta blockers that do not or have not had the research to demonstrate that they're effective in heart failure. They may be good at blood pressure control. They might be really good at cardiac arrhythmia control, but they have not been proven to be effective in heart failure other than these. Okay, next slide. The water pills. There was evidence that aldosterone antagonists like spironolactone do reduce the mortality from heart failure, but it's not a class effect from the diuretics. So in other words, hydrochlorothiazide or chlorthalidone will not prolong your life with heart failure, only aldosterone antagonists. And then just the suggestion that if you are using diuretics, it's measuring the natriuretic peptide would be valuable over time. And I already mentioned that third point there about thiamine deficiency when there's a long-term diuretic use. So getting a thiamine check or just simply supplementing the person with thiamine would be sufficient. Okay, next slide, please. So sometimes the heart failure patient, particularly with advanced heart failure, are resistant to diuretics. So that's why typically we use thiazide, like hydrochlorothiazide or chlorthalidone diuretics for mild heart failure, but then we switch to things like Lasix and Bumex or bumetanide for what we call loop diuretics for either moderate or severe heart failure. And then just an added point there is that if they're still refractory to optimal doses of, let's say, Lasix, you may have to add a medication called metolazone, which acts on the kidney at a little different level than the loop diuretics, and you get some synergistic effects from the combination. And then just the point here of spironolactone or eplerenone for heart failures 2 through 4. New York Heart Class, advanced heart failure. And I guess I really don't talk too much about New York heart failure, but you can maybe that can be a little bit of homework. You guys can Google it and see what the difference is between level 1, level 2, level 3, and level 4 New York heart failure. Next slide, please. Okay, so avoid the aldosterone antagonists if you have kidney failure or you already have hyperkalemia. So I just wanted to point out that when the study first came out about spironolactone improving the lifespan of heart failure patients, we immediately wanted to apply that in our clinical setting, our geriatric patients. But I was really concerned about this first point here about kidney failure or reduced renal function leading to elevated potassium. And sure enough, we took 10 patients, we monitored them very closely, and 3 of the 10 had elevated potassium as a result of starting this spironolactone. So we knew right from the get-go, and then it turns out a study came out about a year later and said, oh, if you got elevated creatinine or low eGFR, avoid giving spironolactone because they're going to get into trouble. The last point here is the kind of gynecomastia. It's a rare side occurrence, occurs mostly in men, but it's a pretty profound. And sometimes you have to worry about getting a mammogram in men because not only is it painful, but you might feel a little lump under the areola. Okay, next slide, please. So when you have diuretics, you can get loss of salt, potassium, and magnesium. And so usually every 6 months to 12 months, I'll get electrolyte panel, including magnesium level. Next slide, please. So I just want to point out that before the ACE and ARBs came about, people were using hydralazine and isosorbide dinitrate in combination. And they said, the research shows that the ACE and ARBs are better, which is true. But as it turns out that this combination works very well in blacks. And so if you have any African-American patients with heart failure, you ideally want to include hydralazine and isosorbide dinitrate in addition to the ACE and ARBs. And the only downside of that is that you're really pushing polypharmacy. So that's kind of a given that just about every patient with heart failure has 6 or more medications. So they're by definition going to have polypharmacy, and we've talked about that before as to why that's a problem. Next slide, please. Yeah, so this is the Entresto. It's just a unique combination, and the big push has been that it reduces hospitalization rates, and just you can't give ACE and ARBs with it because it already has an ARB with it. And by the way, adding an ARB or an ACE to an ARB, ARB to an ACE, vice versa, the two together don't work any better, and they just cause more complications. Next slide. So blood clots are a big problem in heart failure, and you always have to think about it. But as it turns out, there's no evidence that suggests that blood thinners, whether it be aspirin or antiplatelet therapy or anticoagulation, really makes any difference in terms of the outcomes. So bottom line is that we don't routinely anticoagulate heart failure patients unless they have atrial fibrillation. And and by the way, there's a new article out that suggests that anticoagulation in patients with atrial fibrillation and who have dementia makes no difference in their lifespan. And so there's a lot of additional evidence now that you can discontinue anticoagulation in the moderate to severe demented patient. In terms of heart failure with preserved ejection fraction, so that's where the heart squeezes normally, but it doesn't receive the blood normally. So there's a problem with its expansion. And so the heart can't relax as well, and we usually call that diastolic heart failure, or again, heart failure with preserved ejection fraction. And the bottom line is that there's no known treatment for it. So it's always empiric. You try a little bit of this, you try a little bit of that. A lot of these people are on ACEs, and they're on ACE inhibitors and beta blockers, just like they would be for heart failure with reduced ejection fraction. And part of the reason is that that combination of ACE and beta blocker may reduce hospitalization rates. If people gain weight with diastolic or preserved ejection fraction heart failure, sometimes you have to prescribe a little Lasix, and that may be intermittent, like every other day, or it may be just periods of time when they gain their weight and they get back down to their dry weight, and then they just stop until their weight goes back up. So intermittent use of diuretics as opposed to continuous use. Next slide, please. Oh, I just want to mention that, so we've gone through all the medications things, we've gone through the non-pharmacologic treatments like exercise and so forth. So there are devices, right? So we'll go over a group of these. So people with reduced ejection fraction of less than 35% ejection fraction, and if you have a life expectancy of greater than a year, an implantable defibrillator would be a potential recommendation. So the reason for it is that it reduces sudden death. However, if you're 75 and older, the impact on reducing sudden death is not so clear. And so it's really a little bit of a teeter-totter as to whether you want to prescribe something like this for the oldest old. And one of the side effects is that you get these inappropriate shocks. You know, you talk about inappropriate behavior. Well, this is inappropriate defibrillation of your heart. You know, your heart's beating normally and all of a sudden just shock, and you go like, oh, what was that all about? I am very unpleasant. And so that's the wrap on these, is that they can cause shocks. A lot of times, you know, the heart will go into, well, if you ever do a Holter monitor on yourself, for example, you're going to find that you have 3 to 4 beats of ventricular tachycardia or VFib while you're sleeping at night. You know, you can only imagine that if the cardioverter saw this, it goes, oh, beat, bad beat, bad beat, bad beat. Oh, you get shocked. And that's what happens. So if you get one or more shocks, actually, at any point, it really substantially reduces your quality of life, because you're sitting on edge. And I mean, I have very clear, vivid memories of being a medical resident and having to electro convert a heart failure patient in the intensive care unit. And it got to the point where I was electro converting this guy so many times during the day that I just brought the paddles up, and it like psychologically shocked him back into his normal rhythm. So it's very profound, let me tell you. Next slide, please. Oh, yeah. So cardiac resynchronization therapy is basically, there's an electrode in each, the right side and the left side of the heart, and it goes ching, 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 and that's the synchronization. And it really has some great benefits, and not done in a lot of 75 and older patients, but it does seem to work in them, and there's no contraindications for the most part, other than, you know, the whole, well, you know, just the procedure and whether they're functionally impaired or not. So if somebody's like profoundly functionally impaired, this kind of therapy probably would be futile. Next slide, please. Yeah, so, you know, the artificial heart, they're becoming more and more portable and less complicated, with less complications. So it's used in both now non-transplant patients as well as people who are on the list for transplantation. And it seems to have equal application in young and old heart failure patients. So to be determined, it's but they're being implanted more and more. And again, the functional status of the patient should dictate whether these implantable devices make sense or not. Next slide, please. Yeah, and just kind of, I want to wrap up with a few thoughts here, is that heart failure does have a big impact. And so on acute care, both in terms of room, acquisition. So you can even imagine during the pandemic, when the hospitals were chock full of patients with COVID, the exacerbation of heart failure really put a big, twist into the whole room use in the hospital. So generally, hospitals get dinged by Medicare if the patient comes back after 30 days. And you can see that these heart failure patients come back quite frequently, like 1 out of 4 of them will bounce back to the hospital. Half of them bounce back to the hospital after 6 months. But interestingly, and like scratch your head moment, is only 1/3, 33% of these heart failure readmissions are actually due to heart failure. So, what's up with that? So there's not a good explanation. I mean, these people come in with pneumonia, they may have had a stroke, any number of complications, sepsis, infection, you name it, but it's not due to heart failure. Next slide, please. So there's a lot of emphasis on how patients are handled after they're hospitalized. And so it's interesting. My clinical, my geriatric clinic back at University of Illinois, we knew this, I think intuitively, that if somebody was hospitalized, we had to see them within 7 days of the discharge, or else bad things were going to happen. And so that's been pretty well established and observed across the board here. And they should ideally not only go to the primary care doctor, but they should go to a specialty clinic, whether that be a heart failure clinic or a geriatric clinic. The whole question during that time after the hospitalization is, how are they managing things? Like, do they know when to call, or do they wait until they are gasping for air again to go to the emergency room? So there have to be some patient education, some caregiver education, and some feedback, whether it be through telehealth, telephone call, or whatever, are important. And then also we need to, ask whether there's adequate adherence to their medications, their diet. You always ask people about their diet, and you ask them, did they have any fried chicken? And they kind of give you a little smile and say, yeah, I had a bucket of Kentucky Fried. It's like, oh God, they just ate like 2 tablespoons of salt, and that just put them over the edge. And then again, physical activity. Some people just feel like they can't get moving because of the heart failure, but still, it really, is no pain, no gain kind of situation with heart failure. Next slide, please. These are thoughts about medication non-adherence. And again, the third point really about the memory loss is maybe a big driver for a lot of this. Next slide, please. Diet issues. People just don't think about salt on a regular basis. I've had numerous patients that dine out, so that's their main source of food. And then a lot of them just don't understand that, that V8 juice has a teaspoon of salt in it. So things of that nature. And the last point there is in terms of water, if you're on a water restricted diet, and again, that's only for patients that have heart failure of less than 40% ejection fraction, they may continue to drink water because the urologist told them, you better drink a lot of water for that prostate or whatever, so, that 6 to 8 glasses of water may not still hold up when you have heart failure, but they just remember that person, you drink a lot of water, which you should drink a lot of water, but not if you have advanced heart failure. Next slide, please. So the approach is optimized by teams. Make sure you identify the caregiver. If the patient is hospitalized, that's a sentinel event, and really should make sure that patient has advanced care directives. Nurse management of the prescriptions has been proven to be of benefit. And that the patient should always have a scheduled rather than as needed clinical visit. So they should minimally be seen in the clinic every 3 months. Next slide, please. The prognosis for heart failure is not great. So 2 to 3 years. If you have a patient with heart failure, go to the Seattle Heart Failure Calculator. You can Google that, and you can put in the numbers, age of the patient, how long they've had heart failure, and they'll give you the remaining years of life expectancy. And that's really helpful in the discussion of the patient. You can walk them through the calculator, and it's patients always overestimate. They think they have 5 to 10 years more of life expectancy than they actually do. So something like this calculator could be helpful, to at least start them on the process of thinking about, what their condition is going to lead to. Next slide, please. So age is a prognosticator, and you can see on the graph here, this is the percent of people who die at 1 year. And so you can see that it goes up from 1 out of 5 to 1 out of 3 to about 1 out of 2 as people get older and older. So the 1 year mortality is very high in this older age group. Next slide, please. Yeah, and so the big one is if you go to the nursing home, it's a flip a coin as to whether you're going to be alive at the end of the year or not. So again, the nursing home admission for heart failure is a bad prognosticator. Next slide, please. And then the heart failure prognosis is dependent upon some factors. And one of them is that, this BNP blood test, if that is persistently elevated, that's not a good sign. Next slide, please. So the option is to go from curative care more to palliative care. And particularly if somebody has, again, this end-stage heart failure, the New York Heart Classification, with very low left ventricular ejection fraction, they should be referred to hospice. And then if the person has a implantable cardiodefibrillator, the ICD, as they approach the end of their life, a meaningful discussion would be to ask them what they want to have done for their for either leaving this thing on or turning it off. And usually the more prudent thing is to have it turned off, because you don't want to go through those multiple shocks during the dying process. It's just really not very